Okay, good afternoon, ladies and gentlemen. Thank you very much to FIND and the TB Alliance for inviting me to give a talk this afternoon. I thought that it was an extremely good opportunity to start and think a little bit more in depth about what we know in terms of future treatment scenarios and what could be the implications for drug susceptibility testing, because we are presently in quite an important transition area in terms of treatment of new treatment of tuberculosis, and it's time for us to really think about what will be the implication. So in this presentation I will revise very rapidly the pipeline of new drugs that most of you know very well. Then I speak about the potential models of introduction of new drugs or regimen, and then start to have a look at what could be the implications in terms of drug susceptibility testing with the potential scenarios, and ending up with some wrap-up and questions. We all know about the global TB drug pipeline. This version, I understand, now is being updated as we speak, because there has been some progress, so I still show the one dated June 2013. But what is important is that we have a pipeline with new drugs, new classes, repurposed drugs. Some of the drugs are currently in a regulatory process, so are, as we speak, being marketed or will soon be marketed. Then we have to really think about what the implications are in terms of drug susceptibility testing. And we have soon, and Stephen alluded to that in his presentation, novel regimens, which are bringing more questions even in terms of which type of test should be carried out. So let's think a little bit about the various approaches that we can take for introduction of new TB drugs and regimen. There is a lot of factors, criteria, items that we have to consider, because the approaches will vary a lot according to which type of drugs regimen we are speaking about, what population will be considered for treatment, what will be the public health needs, what is the national context, especially regarding the laboratory infrastructure and the level of the availability of tests at the central or decentralized level, district and more peripheral, and what is the local TB epidemics in terms of drug-resistant patterns, which vary a lot according to the countries. So we can then start to think of various potential scenarios for the introduction of new TB drug. And these scenarios, in fact, the advantage of starting thinking now about them is to assist rational decision-making at country level. So for that, we have to address a series of issues, like delivery of the new drugs or treatment, by whom, to whom, and then the access. Who will be accessed and how? The eligibility of the patients and which criteria should be set for eligibility for the new drugs and treatment. And then, of course, the implication for the drug susceptibility testing, which ones, where, and how in terms of placement. And then we have to assess and weigh, balance the variable risk, the risk to individuals, which are related to the safety aspects of the new drugs or regimen, the drug-drug interactions, and the implications of that in terms of surveillance, monitoring, and safety assessment. The risk of irrational use, which is extremely important, especially in some countries where the private sector is extremely important and mostly unregulated. And risk of irrational use concerns the use of off-label or inadequate combinations, inadequate dose or duration, etc. And then, from this misuse and off-label use, the risk of resistance, of development of resistance. So if we want to start thinking about these are the variable approach, and if we want to think about the implications in terms of drug susceptibility testing, then the most important is to try and address what are the key questions. And here I refer to a paper that has been recently published in Lancet Infectious Disease, and where I could pick up 4 or 5 main points, which are questions to address for drug susceptibility testing. What is the intended use? Where should we be placed? Which priority drugs should be targeted? What are the sensitivity and specificity thresholds? And what are the costs related? And these questions should drive the definition and the development of drug susceptibility testing. So let's look back about what is possible presently, what is available on the drug pipeline, and from what is available in the drug pipeline and the development of various regimens, which type of scenario we can start proposing or envisaging, again, for rational introduction and use. The first one is the one which we have been already confronted with, is the new MDR-TB drug, and that's example of bedaquiline and soon maybe of delamanid. It's added to an already existing MDR-TB regimen. So it's a single add-on of a drug to an existing regimen. The second is a new MDR-TB regimen, and that is the examples of the so-called short course Bangladesh regimen, 9 months treatment of MDR-TB, which would be a new MDR-TB regimen that would be introduced as such for treatment of MDR-TB. The third situation is the new drug susceptible regimen, and that is the example of the substitution of one of the drugs with a fluoroquinolone. So this is the example of the REMOC study or the catifloxacin trial. And the fourth is a completely new regimen where we are excluding isoniazid and rifampicin. We don't consider about the issue of multi-drug resistance per se, and we're speaking about a regimen that is capable of treating together drug susceptible and drug resistant patients, and this is the example of PMZ. When we look at those as potential scenarios, then we can start going back to the criteria which were set up by Wells in his paper and try to see how could we start addressing the response. So intended use, well, the test results should be able to inform treatment initiation decisions. So that's what we are to look at that. What is clinically relevant? Because we want the patients to receive the most appropriate and effective treatment. Placement. We want access. So the placement should be the nearest to the patients, excuse me, so preferably put at district level or microscopic laboratory level. Which priority drug should be targeted? Here we have a series of situations because it's all depending on the configuration of the new proposed regimen and the knowledge we have from the drug resistance surveys. And here we have to find a compromise between what is possible, what is suitable, and of course that will be informed by the needs. And then the criteria set up by Wells about sensitivity and specificity, I think, should be taken a bit more largely, and I speak here about accuracy and reliability of the test. And it's all determined by the positive predictive value and the negative predictive value, as well as the capacity of the test to detect the most common mutations which are associated with particular resistance. So if we consider these questions and go back to the fact that we have potential models, I propose that we start looking at the various models and what they imply. It's an extremely busy slide. I'm not showing you this slide so that you take time to go through, but it's just to tell you that we are presently at WHO having this is the type of thinking we have for the rational introduction of new drugs. And we are contemplating these 4 models, which I just presented. Yeah. So the 4 different models, and for each of them, we try to assess a series of criteria in order to define how these drugs should be introduced, what would be the setting of introduction, what would be the means of introduction, what would be the monitoring options in terms of whether the drugs has been approved conditionally or fully approved, what's in terms of introduction, the way it should be done, and then the laboratory implications. So this is a work that we are presently doing with the Task Force on New Drug Policy Development, and this is work in the making. And I'm going to focus now on the last row, which are the laboratory implications. And I will go through each of them one by one and try to think and make some suggestions about what we needed. So in fact, I mean, the last slide showed by a precedent speaker was looking at these aspects, and I think it's more or less a repetition by trying to look at some specific aspects. So it's the example of the new MDR-TB drug add-on, like bedaquiline and maybe delamanid. And here, what I propose here is to consider the must-have in terms of what are the DST which are, in our impression, necessary, indispensable, and what are the advisable ones, and what could be the needs and potential placement. So if we consider that we add bedaquiline to MDR-TB background regimen, optimized background regimen, then of course we need to have a test assessing the first-line drug resistance isoniazid rifampicin, because we need to be sure we're speaking about MDR-TB. Then in terms of second-line drugs, we need to have a test which is assessing fluoroquinolone and injectable, because we are proposing, especially in the guidance that WHO has issued, the fact of treating patients with bedaquiline when they have MDR-TB plus complications such as additional resistance to fluoroquinolone or injectable. And usually the phenotypic tests are currently recommended. What would be advisable for the second-line drugs are the resistance to all these ones, cetazarine, pyrazinamide, etc., knowing that we are very, very much limited in the current situation. And then advisable PZA, knowing that we have problems with assessment of PZA, and I will speak about that later. Additional needs, of course, we need to know about drug resistance to bedaquiline and to delamanid if introduced, because of the monitoring to try and see how it develops and what is the effect of the introduction of the drugs on the emergence of resistance to that drug. And what is needed is transfer of technology. And this transfer of technology is necessary because there is the problem of placement. Presently, ofloxacin drug resistance surveillance is usually done at national reference laboratory level. And the LEVO and MOXIE, it's usually not done at the NRL routinely level. And it's mainly done at the super reference laboratory level. So there is a transfer of technology and know-how which is needed and that can be transferred, but we need to make sure that it is being done. And for the other second-line drug, DST I mentioned here for the group 4 drugs mainly, the DST are not done routinely, and there is a problem of quality assurance. If we consider the second model of new MDR-TB regimen, the example is the short course Bangladesh, so-called Bangladesh regimen, then the must-have are again the isoniazid and rifampicin, and if possible, testing for fluoroquinolone and injectable, because mainly when we consider that the Bangladesh regimen might be optimal in terms of efficacy in areas where the experience of former SLD second-line drug treatment is very, very small and limited, and that's mainly these patients that the Bangladesh regimen is likely to work. So we need to address the potential issue of resistance to fluoroquinolone injectable in these patients. Again, phenotypic test recommended. What would be advisable is PZA with, again, the caveat I mentioned earlier. The need, again, transfer of technology, and for placement, the same as before for fluoroquinolone. If we are speaking about drug-susceptible regimen, like Remox might be the case, or the result of the trial with CATI, must have, of course, are, in addition to isoniazid and rifampicin, assessing the susceptibility to the fluoroquinolone, because we are speaking here about the use of fluoroquinolone for drug-susceptible TB, and we need to know at country level what is the pattern of resistance to fluoroquinolone, and we might consider of using that at patient level as well. There is a difference here, again, looking at OFLO and LEVO. I put CATI in brackets due to the problem of procurement of CATI at present, but it is there. The trial has been done, and you will hear the result next Sunday. In terms of needs, training and technology transfer, as I said before, and then we have, of course, to clarify the issue of cross-resistance among the fluoroquinolone, addressing the fact that if we have only information of ofloxacin resistance, how much can we transfer to the knowledge of resistance to moxifloxacin? So some issues, concerns here related to that is that there is marked regional difference in prevalence of resistance to fluoroquinolone, and then we have to consider also that fluoroquinolone are a critical element of treatment of MDR-TB. Then the last scenario is the completely new drug regimen for drug-susceptible and drug-resistant TB. And the must-have here are really dictated by the composition of the regimen, and I give the example of PMZ, is that we need to have fluoroquinolone, PZA, and PA24 to be developed. I don't know about the development so far, but it is a must-have because we are here in a situation where we don't want the patient to be treated in a mono or B therapy. So the sensitivity to the elements of this regimen have to be considered. In terms of needs, training and technology transfer, as I mentioned earlier. So the point I just made is the fact that if we want to have a baseline rapid testing for MOXIE and PZA, that should be done in all TB suspects because of the problem of mono or B therapy. Placement, it will vary according to countries. The problem is to make sure that we have a decentralized toxicity testing. It is needed. And then try to work in a type of expert plus test, using the molecular technology that would allow a decentralization of the testing and then of the treatment of the patient. So I mentioned the case of pyrazinamide resistance. The problem is that it's still poorly known because the mode of action is poorly known. We are speaking of pyrazinamide, which is in fact a prodrug. And the problem is that the prodrug is converted in a pyrazinic acid, which is the element which is active, by a pyrazinamidase, an enzyme, which, if absent, indicates a resistance to the drug. And we are presently in a situation where we do not have any gold standard for the detection of resistance to pyrazinamide. So this leaves us with some problem that has to be addressed. I was coming to speak more about that, but time limited. I will just go to the following slide. In order to address the issue about what would be the best placement, what would be the best test to consider for the various scenario, what would be the test, the best profile of test to be developed, the CPTR has recently launched what is named the CPTR Rapid DST Forum, and I present that here because I think it's exactly the type of initiative which is to be supported and to be contributed to, because it addresses exactly the problem I mentioned in my former slides with the various tables of trying to identify which type of test should be done or should be tried to be developed, where should be placed and how, and using which technology. So the objective of this CPTR Rapid Test DST Forum is to accelerate the development of a WHO qualified, clinically useful in vitro diagnostic assay for the rapid drug stability testing of TB to facilitate drug development and rational use of new drug or regimens. There are 4 working groups which are working in parallel. The first one is called Enabling Science, which focuses on discovery and validation of the molecular basis for resistance and correlation of resistance to clinical outcome. The second is assay development, which is for developing rapid TB-DST assays and meet target product profile. The third is on surveillance, in order to improve the understanding of the magnitude and trends of drug resistance surveillance in high burden countries. And the fourth is economic assessment and modeling, in order to try to develop models to inform decision making in terms of target profile and potential policy for the use of this new DST test with various regimens. So in terms of wrapping up, which lessons can we take from all that is that we are in a transitional phase of TB treatment, and that increased the need to adapt and develop the new diagnostic tools for drug resistance. And as I've shown, in the 4 types of scenario which we can propose, we see that we need more than what we have presently. For all this stage, what we need to do is to consider the clinical utility and the capacity to improve patient management. And for that, we need to have the potential future treatment scenarios being carefully examined so that we can develop specific and judiciously selected target product profiles. For that, we need information on prevalence of resistance to key drugs in new TB cases, but also in retreatment cases and in MDR-TB cases. And that's the type of work that we're presently carried out, WHO, with expanding drug resistance surveillance to isolated rifampicin, but also to fluoroquinolone. And we have, of course, to consider the geographical variations in terms of epidemiology, prevalence of resistance. And last but not least, the cost of the test, because it will be determinant on the capacity to get access, the placement of the test, and access to the test by the patients. So I finish here with many thanks to the Task Force on Drug Policy Development, who is advising us and with whom we are working, developing what we call the policy implementation package, which is helping countries with a view that new drugs and new regimens will be soon in a situation of being adopted and implemented. So we are developing this package together, and I took this complicated slide with the various scenarios from this policy implementation package. And then, of course, it can inform a series of activities like the one of trying to identify the best DST test. So here are the members of this WHO task force, and I would like really to thank Martina Kasangi from MSF, who's been extremely helpful in the discussions for preparing this presentation. And I want to thank BMGF, Bill and Gates Foundation and USAID for the support for the work we are doing. And I thank you very much.